Коллеги, мы начинаем. Спасибо большое.
So, all right, let's get started. Thank you, everyone, those who joined. I think it's going to be a very valuable and impactful meeting for all of us that is organized, as usual, in several languages, in English and in Russian. That is why please choose the language that you feel comfortable listening at, working at. We have simultaneous interpreters, Anna and Chris. And if you prefer English, then choose the English channel. If you prefer Russian, then please select the Russian channel. So all the webinar will be available in the relevant language. Most of the speakers are also bilingual, or we have simultaneous interpretation available for you. A couple of words about PASTE. Maybe you've been with us for quite some time. Maybe you're already a child participant. Maybe you're already a speaker. But for those who are just the beginners, who have never been working with us before, I'd like to introduce PASTE, our organization. My name is Anastasia Gulaeva. I'm in charge of strategic development of the fund. The fund PASTE is a British organization that provides improvement in the quality of palliative care in the areas of presence, such as Central Asia, the Caucasus, Eastern Europe, and the Baltic states, through learning and development. Why we say that these are just our regions of interest for now? We say so because we notice a lot of different countries that are interested in our programs. We notice new countries joining our presentations, and please get in touch with us if you feel that there are some areas of mutual interest. In order to stay in touch and to prep some very high quality information for you, you can feel free to subscribe to our newsletter. You can read the notes and the summaries of our webinars, watch our webinars on YouTube. Most of our webinars are available in 2 languages, but there are also some of the materials that are localized. For instance, the webinar that were organized by our Georgian colleagues, it's also available in Georgian. We really strive and work hard so that all of our countries of presence would find the formats convenient and comfortable. And we really work on the accessibility of our materials. So we're looking forward for you to join our for our emailing list. We are collecting and creating those articles based on our very professional sources. We're creating the summary so that the professionals can receive high quality information with a very short period of time, so that you don't waste time reading all those long details. So our main task of PASTE is to be practical and useful for you, dear professionals. And finally, if you work in one of the countries that I've mentioned, in one of the regions that I have mentioned in the areas of interest, please join the chat of palliative care specialists. This is the chat where we share our findings. And sometimes the colleagues also join each other. The participants also welcome each other to join their professional events. So looking forward to seeing you in the chat. Speaking of our today's webinar, a couple of important words. Let's say a year ago, we have launched a series of thematic webinars. How palliative care is organized in different countries across the region. It turned out that the majority of professionals, specialists, experts, and speakers of those who are right now within our perimeter, they are focusing on palliative care for children. I do hope that the materials provided today will be also impactful and interesting, regardless of whether you're a child professional or an adult professional. To summarize, today we wanted to make a roundtable to summarize all of these experiences that we have covered already. Not only to speak about the current state of affairs in palliative care for children, but also to speak about the challenges and the difficulties that exist for child palliative care in different regions of our presence. And I'm very, very glad that today in this roundtable, we have 13 speakers from 6 countries, 6 plus actually. I would say, why 6 plus? We have one guest that represents a whole network of professionals, not even a country. So we will speak about that shortly. To those who have joined us a little later, I would just like to make a kind reminder. You can choose the channel that's convenient for you. You can choose either English or Russian for your listening. And a couple of other important housekeeping moments. Of course, we have the summary. We will have the summary, we'll have the recording. So during the roundtable, we will not always have an opportunity to answer all of your questions, but I hope that even if we don't have enough time to cover all the questions, you'll be able to contact us directly. And I'm glad to introduce our today's experts. Of course, the experts are much more represented in every of the countries, but the time is limited. That's why we have only a few experts from each country. And we're very grateful to all the experts who have joined us today. It will be chaotic. It won't be alphabetical. It's not any specific order. I just have a cheat sheet, and we'll begin with the colleagues from Uzbekistan. So we have Rustam Norbaev, the head of Child Hospice Taskin, and Nodir Rakhimov, the director of Samarkand Regional Interregional Hospital. We are very glad to see you. Colleagues from Armenia, with whom you can read the interview on our website. This is Narine Movsesyan, anesthesiologist, the tutor at Yerevan Institute, and the head of the specialist in palliative care and pain management. And Anush Sargsyan, a colleague of Narine, a pediatrician and a rehabilitologist, the head of Child Department of Palliative Care in a hematological center named after Professor Ilan. Thank you very much. Colleagues from Latvia, Anda Jansone, the founder of Palliative Care for Children of Latvia, the head of the Society for Child's Palliative Care, and the head of the Psychosocial Rehabilitation Service and Palliative Care for Children, international expert of ICPCN. Yulia Cirule-Galuza, the head of Liepaja Service for Palliative Care in Liepaja Regional Hospital. Thank you very much, Yulia, for all of the initiatives and your support that you're providing. Thank you so much. It really means a lot to us. Dear colleagues from Belarus, Anna Gorchakova, the director of Belarus Child Hospice, the head of the course in palliative medication in Belmapo, and Olga Skorbenko, the head of board of directors in the Public Union of Kids for Children. All right. Preterm birth children. Okay, so we have our colleagues from Kazakhstan and our colleagues from Georgia. From Georgia, Irakli Vetsko, the director of Child Hospice Free Fly World, and Nino Kiknadze, the founder of Child Hospice Firefly World. And from Kazakhstan, we have Yulia Streletskaya and Nurila Maltabarova. Yulia is the anesthesiologist, reanimatologist, the head of Center for Respiratory Support and Palliative Care and Rehabilitation, and Nurila is the head in the department, the head of chair in child anesthesiologist, intensive therapy and emergency support in Medical University of Astana. And we also have a special guest, Julia Downing, a member of International Child Palliative Care Network, and I'm sure she's going to give a great impact to our professional discussion today. We have a very representative, a very, I would say, fantastic team of experts that we have today. I'm so sorry that we have a very limited period of time today, and I hope that's not our last meeting. With some of you, I'll see many of you during our summer school in Armenia. With the other experts, I'm sure we're going to see each other at the other professional events. So, today we have 4 important questions to be discussed, and for each country and each group of experts to share their view, their opinion, their answer to this or that question, we'll begin with the general question to make sure everybody's in the same information field, in the same information context. The first question is, At which level do you find each of the four components of palliative care, medical, psychological, social, spiritual, in your country when it comes to pediatric palliative care? Of course, when we speak about the history of palliative care, there are certain cultural components, there are certain political components. This or that component may be at a different level. So the question is to you, to each of the speakers. We have an important limitation, unfortunately, 5 minutes only per speaker. And in the end, we'll also ask Julia to share her opinion from, let's say, to give a helicopter view, to have this helicopter perspective. How does it work globally? We'll see how it works. I don't know if we'll be able to take your questions in the time being, but always keep them in the chat, always put them in the chat, even if we don't have enough time to go through them in the moment, we'll be able to do that afterward. So let me begin by yielding the floor to colleagues from Uzbekistan. Hello, my name is Rustam Norbaev. I'm the head of Child Hospice. And let me quickly try to answer this question. Recently, I've been performing a report on the development of palliative care in Uzbekistan, and we were joking that palliative care, child palliative care, pediatric palliative care, is almost like Schrodinger's palliative care. It's there and it's not. When it comes to palliative care in Uzbekistan, we usually say that we speak about oncological patients. Other patients are still not under our area of influence, I would say, because the national protocol for kids with pain and some other syndromes, they're covered by other types of support, not palliative care. And so for now, we're mostly focusing on oncological patients. Psychological support is unfortunately not developed at all. We have not oncopsychology support. We only have one psychological professional who has completed her studies in Moscow, but she has issues with Uzbeki language. Most of the population speaks Uzbeki, so this person supports us methodologically. Another colleague we have, she had master's degree in psychology, but I'm not sure she's very professional in this regard. So it's like almost zero level of psychological support. So we've been working on that for the recent 2 years, but we had to work on that experience, do trials and errors. So all three of us, we had to learn do our trials and errors. Then we went to Israel to do a short course of studies, but we really don't have an opportunity to study in our place. When it comes to social support, we have recently developed an agency of social support under the auspices of the cabinet of the president of Uzbekistan. These standards are still not being developed, and we are very slowly progressing in that. Still not there. And the social workers and all the system does not provide proper support for now. But we hope that within a month, when the standard will be released, we'll be able to work with that. When it comes to spiritual support, we have a lot of questions when it comes to religious issues. We ask, because we are a Muslim population, there is always quite a request for mullahs or the spiritual Islamic leaders. Nobody has been teaching them how to work with these children. For most of them, it's a shock when they see kids like that, even for them. And sometimes they are not able to answer the questions that kids ask. And so I think for them, it would be quite important to be taught, to be prepped. In Uzbekistan, the fact that we have just started the hospice and the palliative care is just becoming a little bit more popular. But still, it's quite a low level for now. That's the first block. Should I keep coming, or? I think we're good for now. Thank you very much. That's good. Thank you. Maybe Nodir would like to answer and add something on top of what I've said. Maybe you can ask him as well. Nadir, would you like to add something when it comes to the level of development of pediatric palliative care? Nadir, okay. I forgot to add about the medical support. We have it was supposed to happen today, the new forms of morphine, but there were some issues in the customs. So far, we only have injective morphine for kids and adults. We also use tramadol, but we're just explaining to doctors that tramadol is not being recommended to kids. So, but I hope with time we will approach that. And in December, we will also have fentanyl patches, and I hope that in the future we will be finding some other forms of pain killing. Thank you very much, Rustam. I'd like to yield the floor to my colleagues from Latvia. Yulia, should you start maybe? Maybe Ante can start if that's okay. I can do that as well, but hi everyone, hi colleagues. In Latvia, the situation when it comes to child palliative care, it's been in place for 25 years. This is the 26th year. The system that we have here is built quite well. There is a system, I should say. There is a system for children and for adults. And the services that are being provided by interdisciplinary professional team. So together we have doctors, capellans, psychologists, nurses, and social workers. And as for the time being, we have child palliative care is funded by the government. The rest of the questions I will cover during the next vlogs. Ante has shared what we have. I'll share what we don't have. I work in a more rural area. We have the medical support, but mostly it's consultative support because it's very hard to provide resources for everyone. We really look forward to hospice chambers in regions or hospice cabinets in regions because for now the biggest challenge is for the rural areas. Human resources are hard to find. Psychologists are not enough, I should say. It's, I would say, a bit confusing because we cannot provide proper matching between the psychologist and the child in the right time, and sometimes we're missing this moment. Social support is more or less okay. The problem of our social workers is that we have always changing standards, changing conditions at the level of municipality or the state, and sometimes we always have to replay certain things. The things that were guaranteed 2 months ago may change in 2 months later, and something new is happening. So that is why we have to work with the families because the situation keeps changing. And spiritually, I should say we are quite okay in that. Capellans, they have understood how to work with the hearts of people. The people were scared of the word capellan, of the spiritual support. But right now we have them as friends, as supporters. They are seen as, supporters for the whole family on their spiritual way. There is something to work with that, but we have already quite something. I would like to just add to Dr. Yulia. Our advantage is that capellans are not the spiritual leaders, I should say. They are interconfessional workers. They are professionals. It doesn't matter what religion you follow, what confession you follow, that be a religious or non-religious person, that doesn't matter. This is just a spiritual support. And I think this is important. And one more service that we have, those families that lost their children, during their sorrow, they can also receive up to 2 years of this spiritual support. Thank you. Thank you very much. And it's very important. The kaplans can do lots of things that the others don't have time for. Very often the contact with the family is starting with the even physical support of the kaplan sometimes. Thank you very much, Yulia and Nanda. I have a quick question, if you don't mind.
So one more short question. Rustam has mentioned that quite often there is a shortage in spiritual professionals' education and training. So the question is, did you organize any training for your chaplains, anything like information awareness, etc., to arrange their work with the families? And the second question, do they also involve any community in the physical support of the families, because they also have this opportunity? Right, so to answer this, they are trained in accordance with the American methodology. And now, under the Riga and Latvia University, we have another course for chaplains. And this is for those who wanted to become professionals in the field of palliative care or any kind of other medical support, those who would like to work as chaplains. Right, so first it was quite difficult for them because they didn't get trained and we had to arrange the training. And so when we got the training opportunities, it became better. And as to the community's involvement, it's indeed very important, but unfortunately, it's not possible all the time, because sometimes, well, there are people who can be involved in this, but sometimes there are no such people, and this is still an open question to us. Thanks, dear colleagues. Now we'll go to Georgia. Irakli and Nino, who would like to answer the question now? Unfortunately, we can hardly hear you, Irakli.
We cannot hear you.
Can you hear now?
Yes.
Yes. Okay. Well, good afternoon. Thank you for inviting to this interesting discussion. I'll start with saying that in Georgia, the palliative care is a relatively new field. It's been developing, I would say, a little bit sporadically. And what I mean is that in one sense, as a country, we have certain requests in joining, getting closer to the European Union. So we have to, in one sense, develop this field. But in other sense, it's happening in a little bit chaotic and not very planned way. Thus, out of the 4 components that you identified in block 1 question, all those have been developing in a different pace and also facing different and specific to each of them challenges, although some challenges are similar for all 4 areas. Specifically for the medical component in palliative, in pediatric palliative care for us has been developing, like I mentioned, but it faces significant challenges, and most of these challenges are related to the shortage of the specialized staff who've been trained specifically for pediatric palliative care. Also, the challenges, the limited access to necessary medications and the medical equipment, and not only medical, but also specific furniture, I would say, that is required in pediatric PC. And we also have problems that already been mentioned here in the sense of the painkillers, how we are getting them, how we are administering them, very limited types that we can use that are limited to the liquid morphine. Those are kind of the problems that I think will be similar in at least some of the countries that are represented at today's discussion. But we don't only have the problems, that have been certain improvements as well. And in the medical component, there have been certain efforts are being made currently. And one of them are the integrating of palliative care into the national healthcare system, with support from international organizations who provide at this stage different trainings and resources to existing healthcare providers. But it's like I mentioned earlier, it's on very early stages of development. The psychological component in the psychological support for children and families in palliative care is we also face a similar problem in the sense of limited availability of staff that have been specifically trained in the field. We ourselves, we do have a psychology, an expert on this stuff, but we've been one of the lucky ones, I would say, because there definitely is a shortage of staff who've been specifically trained in the field. But here I want to notice that at least we have the growing recognition that there is a need to develop in this field, and hopefully it will turn into a more tangible steps in the future. Just like in the medical component, here we also notice that there have been support from the international organizations, and mostly through the trainings and different workshops that happen locally, and also initiatives by certain NGOs who have started to address these needs that the specialists in psychology for pediatric care have identified locally. In a social component, of course, there is a huge challenges that families face, which is also probably across the countries, that is related to economical problems. Their financial resources are often exhausted by the time they reach the hospice care. So I think the existence of places like ours, which support them completely free of charge, is definitely crucial for developing the palliative care in Georgia. And also the social programs that are currently existing. And to name one, there is a social program that exists for receiving free of charge wheelchairs. There is also a program attached to it that is a fitting of the wheelchairs, but in practice, the fitting component doesn't really happen because, again, there is a lack of specialists, and also there is basically no access to specialty materials that are being used in fitting the wheelchairs. Some of the improvements are done in a social component. There has been a new program that's been developed of home care services. But again, the platform that's been developed where the home care service specialists have to register, it's not really fine-tuned yet, so to say. Also, the pay is really low, and I would add here that the team that's been selected, it's not a 100% multi-profile team that's been formed for a new home care service project. As far as the spiritual component, I mean, it also has it's facing certain challenges, and maybe it can be said that there is limited recognition and integration of spiritual support within the healthcare system in general. And there are very few, if any, trained chaplains or spiritual advisors that will be easily received by people, regardless of their religious beliefs. There's been certain efforts made to incorporate the spiritual care into the system, and they are mostly driven by the NGOs. Most also driven by the NGOs, but still it's the perception and stigmatization in this field still is on a pretty high level in the society. In summary, I could say that the primary challenges include a lack of trained professionals, and in often cases it's related of people just leaving the country and searching higher paid jobs, often less qualified, but outside of the country. Also, limited access to the resources, like I mentioned, it will be medical or painkiller resources or specialized furniture, and insufficient integration of palliative care into the healthcare system in general.
Спасибо большое.
Maybe I can add any comments.
Я думаю, что мы...
Thank you very much. I guess that comments or questions will be provided later, because we would like to give everybody the opportunity to speak. Now let's go to Kazakhstan, and I would now like to give the floor to Yulia. Hello, dear colleagues. So, as of today, palliative care, pediatric palliative care is at the stage of integration. So it's dispersed in different regions of Kazakhstan, and we don't have the multidisciplinary framework for this. About 60 children need palliative care now in Kazakhstan, but there is no official register, unfortunately, and most of them are in ICUs, in the children's homes, or also at home. And so, as colleagues already mentioned before, we have the medical component here. We have special palliative beds. We have 2 palliative departments in our country. But the specifics of this medical component is, I would say, it's too medical. So it's more about treatment. It's not about palliative care. We still have it. Mostly it's about inpatient facilities. When it comes to outpatient facilities and support, such as provision of some materials, some trainings, even some special food, unfortunately, we face some problems here now. Also, just as colleagues mentioned, we also face a challenge of painkillers. We don't have a lot available for children. And the second component for us is the social one. And well, we do have social workers who help at home. So they do some work at home, or they can also help with documents, for example, when some expert assessment is needed for a child. And also we have some very good volunteering teams. At the same time, the negative aspect is that we don't have any programs over social breaks for parents, so to say, and it also is a problem in palliative care, and it's a problem for families. As to the psychological support, we do have psychologists in our hospitals and in clinics and outpatient facilities, but they are not always prepared to work with palliative children and palliative families. So we actually have almost no professionals who can work with a family after the death of a patient, because there is no finance support provided for this. And another problem, just like in Uzbekistan, we have some problems with psychologists who speak the local language, Kazakh language, for example. Not all our psychologists speak the local language. As to the spiritual support, that's most challenging aspect, I guess. Well, first, we do understand that any disease which is very serious, it's about life and death. And well, of course, we need to integrate the spiritual aspect into the pediatric palliative care. Well, we don't mix those concepts, spiritual support and religious support, but still we opened some prayers rooms for Muslims in our hospitals and for Christians, for Orthodox Christians. This is a development, but at the same time, we don't really have the spiritual communities, because this is the component of a palliative care that is not that developed in our country yet. A lot of functions are performed by non-governmental organizations now, and also they actually carry most of the burden. Okay, Yulia, thank you very much. Nurila, maybe you can add. Right. Hello, dear colleagues. So I'm a coordinator in the field of palliative pediatric care in the city of Astana. So I will not completely agree with Yulia when it comes to the medical palliative support, because I think as of today, we've developed a standard for palliative care organization. Now it's the standard for everybody, for both adults and children, but we have a separate association of pediatric palliative care in Kazakhstan. It's a non-governmental organization, and together with this organization, we are currently asking to develop the separate standard for pediatric palliative care, because the one for adults and the one for children are two different things. When we talk about adults, it's mostly about oncology. But today, also children with orphan diseases need palliative care. Also, children with oncology and with serious damages of their central nervous system. So they're all patients in palliative care, those children. Also, unfortunately, for a long period of time, we didn't develop any registry. And together with the Association of Pediatric Palliative Care, we've currently developed a registry. Now we are starting with the city of Astana. So as to the medical care, right, sometimes we had to treat children intensively because now a lot of children are still using the ICU beds. So basically they are in ICUs, and there is some misunderstanding between parents and the medical staff, right? Because if a child is in ICU, some treatment should be given. This is also required by the parents. And now, together with the association that I've already mentioned, we started to do the feasibility study of medicines that palliative patients get if they're in ICUs. And so we compare it with the finance that will be needed if there'll be separate centers for palliative care. Now we are only working on this in 3 major cities in Kazakhstan. And as to the social support, well, parents do get some benefits, financial benefits, but now we also continue to monitor it. Now we have a special foundation, and together with the Center of Pediatric Palliative Care, we are developing the list of equipment that will be needed for those specialized palliative care centers. So now we are turning maybe not 360 degrees, but 180 degrees to change the angle of this problem. Right. Thank you very much, Nurila. And now let's go from Kazakhstan to Belarus. And I would like to ask my colleagues from Belarus to give your comments on the aspects mentioned above. So who'd like to start? Anna, I guess you are still on mute. Anna, maybe you could unmute yourself. Right. Good afternoon. So I'll talk about how nice it is to live in a so-called post-Soviet country. So now we are considering all 4 components that you mentioned, medical, social, spiritual, and psychological. Right, actually, I think that in Belarus, we have the best palliative care in Europe, and I'll prove it based on the papers. So we have our Center for Palliative Care that's been in operation for 30 years, 30. And so starting from 2016, our government also got involved. We have the registry for pediatric palliative care. In each and every region, we have a center for palliative care. In each sub-region, we have the special room for palliative care. We have also facilities for different kinds of care, and we do it at all the levels. So we also have the morphine that is available for children as well. And I was hearing and was listening to my colleague from Uzbekistan, and actually what we have is the opposite. For example, I come from the oncological field, right? Now we have 80% of our patients who are not with cancer. So our children get checkups, undergo checkups 4 times a year, etc. But 20% of our oncological patients are not there yet anymore. The answer to this is because we don't have oncologists. So no oncologists, no palliative care in the field of oncology. I guess that, well, on papers, our palliative care looks beautifully, but I would like to be more realistic. Like, yes, we have it all on the paper. And when it comes to the social support, we have everything for free, like different cough assists, different artificial ventilators, etc. Actually, it's available even not only on paper. So we have it all. You have to keep asking for this for a long time, but still. As to the psychological support, we have a lot of psychologists. We don't have any shortage of psychologists. We used to have a lot of lawyers in the past, but now we have a lot of psychologists. No problem with that. And it seems that, well, everything is fine. As to the spiritual support, we have our spiritual leader, Roman. And so we tried to train chaplains, and we tried to take the cue from the American experience and the British experience. But I think it's very difficult to do this in a Muslim country, right? So we need to have a priest, actually. And so our Father Roman treats all the religions very well. So he works with Catholics, with Orthodox Christians, etc. But of course, like I shouldn't be too optimistic or to be over optimistic here. So I would now like to talk about some challenges. First challenge is the education and training. Who works in those centers, in those rooms for palliative care? Who are these people? And so, second question and second challenge is the integration. Right. So the question for me, who is a palliative care and responsible for this, and who is the pediatric palliative care? Now, for example, children with SMA, they get more assistance and support than those children who really need some emergency support. We also have a lot of rehabilitologists, and they are quite well trained. But now I've started criticizing all this, and I still want to say the following. First, in accordance with our law, we don't have palliative care. We have palliative medicine. So our healthcare ministry monitors all this, but our social support and education ministries are having some troubles with this. That's why we can't really have a comprehensive approach towards palliative care. So the second factor here is the human factor, because palliative care is not possible without the human factor. So we can be talking about palliative care for a long time, but human factor is a key here. And so there are some challenges, and I guess my colleague Olga will also talk about this. She's from RANA. This is the Public Association of Parents with Premature Babies. So she'll talk about these challenges.
Yeah, unfortunately, that needs to be short. I'll be super short, yeah. Of course, I'm dealing with a certain category of parents and families. Those are preterm children, preterm births. I need to join Anna Gorchakova in what she was mentioning. In the medical system, that's true. Kids are being very well taken care of 23, 24 weeks. And our stats does not differ from the official stats. But we have a lot of questions when it comes to communication with parents, when it comes to routing, when it comes to when you can receive this support, because those are newborn kids. They've never been at home. They are in the emergency therapy. Sometimes they are spending up to half of a year in hospital. So that's the question of how a family can communicate. What's the palliative status? There's so many gaps when it comes to communication that brings the other consequences. The parents have very little choice. They don't fully understand what it means that a child is in the intensive care unit, or the child is in the orphanage, left. For example, a child may be left in an orphanage. What does that mean? Sometimes you don't even have a chance to get a proper consult. So that's the complicated forms of lung issues, for example. That's very hard to receive as a consultation in the first months. This is a child who doesn't have papers, doesn't have official papers to make sure there is a limited ability or disability status. So there are so many issues, and we're trying hard. Our parents sometimes are lucky because we work very closely with the hospice, but it's not a state-funded structure. We have a strong communication issues with the government. There is also a question of available human resources. It very much depends on the human factor, who specifically communicates with parents, who's ready to communicate with non-commercial structures, etc. So the questions are here, but we're working on them. But yeah, we hope that we will be educating and doing the enlightening even further. Thank you for sharing. Let me bridge this comment to the next speaker. But before we do that, the colleagues from Armenia, Anush, Narine, they say they don't have such a stable internet connection, but let's give it a try. Hi, everyone. I'll be short. Not everything is good. We have two centers. One is our centers, named after Yulian, and it's for oncological center, opened in 2021. It only has 5 beds. The medical and spiritual aspect is all good. We also have Uramor. We don't have children dosages for the pain relief. You know, I think that's the bottleneck. We don't have. Excuse me, there is one more center in the child hospital where we only have medical support. There are 3 beds, and those are the kids who turned out to be palliative during the treatment, not to send them to home. They live their life there. Social, spiritual, and psychological aspects, they are lacking there very much lacking. We also don't have mobile service, home-based care. Yeah, kids don't get anything in their houses. If they are in Yerevan, in the capital, at my own initiative, I can try to support them. I can attend them myself. But if it's beyond the capital, then it's nonsense. It's, no registry, nothing. And I think it's underfunded by the government. Of course, it's not enough for all sorts of support. For example, some funds give some support, and that's it. It's mostly the funds that give us support. Thank you very much, Anush. Narine, would you like to add something? Hi, colleagues. Thank you very much for the invitation. The only thing that I wanted to add is that our social services are in very much starting phase. Some changes are happening, mostly in adult palliative care. This is the standard approach like it happened in the Soviet Union times. I think nobody was interested in anything apart from medical criteria, so I think that's still there sometimes. We are trying to look forward to international standards, and I'm very much relying on the non-governmental organizations in this regard, but the understanding of the social, psychological support, it's lacking. This understanding is lacking, but we're working on that. But the rest, Anush has already mentioned. Thank you very much, colleagues. Julia, I'd like to ask you a question. There's this different spectrum and stages of development from different countries, as we have heard. Somewhere it's been for 30 years, somewhere it's 25, somewhere it's just the starting, emerging seeds of some positive changes. In your opinion, Julia, looking at this development of pediatric palliative care globally, what do you think? Are there any commonalities or tendencies, or maybe you can calm us down somehow that it's all right, that's been happening like that everywhere across the world?
Thank you very much. And it's great to hear from our colleagues in the different countries, and great to see friends from many years. It's really interesting hearing the range. As you said, we've had services in countries for over 30 years, 25 years, and then services beginning in other countries. But there were common things that came out. And I think even in those countries like Belarus and Latvia, where things have been very well developed, some of the commonalities that came out included the types of children that are being cared for. I think it was from Anna in Belarus, where 80% are non-oncology children. And yet in some of the other countries, there still seems to be a tendency to focus initially on oncology. And so that's one of the commonalities, is how do we make sure that pediatric palliative care is available for children across different conditions. Interestingly, if you look at the development of pediatric palliative care in many countries, it often starts with oncology and then spreads out. So what are the lessons learnt there? I think one of the key things was education, and various people were mentioning a lack of pediatric palliative care specialists in their countries. So education at the specialist level, but also general education, so that every nurse, every doctor, every social worker, psychologist has some pediatric palliative care training. So the types of children, education, integration, trying to get pediatric palliative care integrated into the health system so that it's available for all. And I think some of the different things also that came out were, in some places it's available at home, in other places it's more facility focused. I think a couple of people said it was okay if you lived in the capital, but if you lived in other parts of the country, it was quite limited. So integration there. The whole holistic nature, the medical services, but then the whole social, spiritual aspect was a challenge in some countries, and bereavement support. So how do we ensure that the whole holistic nature of pediatric palliative care is available? But again, often when you look at the development of pediatric palliative care, it tends to started more focused on either the social or the medical, and then bringing in the wider psychological and spiritual aspects, bringing in the bereavement support. Two other things that I think came up in many of the presentations were access to medicines. Some countries are doing well in that regard and are able to access medicines such as opioids in pediatric formulations. I think there was a couple of countries who said they could access morphine, but not in pediatric dosages or formulations. So access to medicines continues to be a challenge, and we might come on to that later, but that is something that again we hear in countries around the world. And as the International Children's Palliative Care Network, we're trying to work to help with that. And then just the last thing to pull out here, I'm sure there'll be other things later, was several people mentioned standards, and there are recently some new revised global standards for children's palliative care that we can draw upon to help us in developing standards. So I think there were many themes there that do run through all of the countries. Some, yes, have been able to develop pediatric palliative care over many years and are doing amazingly well. Others are beginning to start and are beginning to move forward, which is great. So a lot we can learn from each other.
Джулия, спасибо большое за такое summary, выделение ключевых моментов. Это очень
Thank you so very much for this summary and these key points. It's important to hear from the external perspective. I have just also noted down several ideas for us as for PACE, but we'll move on to that later in the end of our roundtable. The third and the fourth questions that I had, I wanted to combine those questions. We wanted to ask the question, where are the growth zones that are the easiest for you now? And the fourth question was about which are the most challenging areas of growth. So can you try to combine the two questions, if that's all right? Each country representative, please, would you be so kind to combine those answers? In the first round, we usually speak about not only the advantages, but also the challenges and the disadvantages. So let's make it more comprehensive here. Which are the quick, low-hanging fruits? Which are the most achievable, attainable areas of growth? And the second question is, which are the most challenging areas? So let's do a different order right now to make sure that the waiting time will be different, and we'll begin with Armenia. Let's begin with Armenia. Narine, Anush, any one of you, you're welcome to please answer this question. I can add and say that we have lack of funding. We don't have niche specialization in pediatric palliative care. That's a great question. Even those doctors who want to be professionals, there are no areas where they can learn from. There are no places where they can study. I hope we will start a more global service provision here. The government has secured some money for that. We will start this year, and later on, we'll see what kind of advantages and disadvantages it gets. We are starting from the capital, and then in the other areas, it becomes a question. And also preterm care, it's a big issue, I think. Thank you. So the quick growth zones is the mobile services, and the others are the challenges. Okay, thank you, Anush. Narine, would you like to add anything? What are the quick growth areas, and what are the slower? I would agree with Anush. The only concern I have is that the systemic approach of the Ministry of Healthcare, I think the ministry should understand that, of this service. However hard we try, this burden, this responsibility, the ministry should be interested in that, because there is this, it's a burden, really. I really don't know how to put it otherwise. There's a burden and a heavy task of keeping those kids in the treatment. I think this should be a push for our government, so that these services should be comprehensively connected. As they say, there is no political will to do that. It's mostly that they're focusing on operative care, preventive care, and the system of the healthcare is definitely overloaded because of that. There is this understanding, I think. I don't know how hard we tried to convince this idea. Still, there is this result, I would say. Thank you very much, Narine. Let's move to the countries where palliative care has been for quite some time. Yulia and Anda, what are your areas of growth and the challenges? But it seems that you guys are doing quite well. Who will begin, Anda or Yulia? Let me begin. Those areas where we work, it's legislation, education, and accessibility. For the time being, Yulia can speak about that in details, but I'll just say that we are developing our regional accessibility. We hope that the services should be closer available to the residents of our citizens. When it comes to education, we have specialization in the educational system. We have different areas of training for social workers, for doctors, for kapellans. So it is there. I think we are also focusing on the community outreach for the general public. But what is hard and what is slow is the work over the ministries when it comes to legislation and when it comes to the laws, of course. We do want to improve the accessibility.
Законы, чтобы насчет развития были стратегии в
So that there will be strategies from the ministry on the terms of development. We also have the welfare ministry in our country. So this is super slow, super slow. The red tape, bureaucratic development, it takes years. Yes, thank you, Yulia. If we think about those questions, the second question is, what is the easiest thing to change? And what we see on the cutting edge, the thing that really is worked well in the world and is developing, it's the digitalization. And I think in general, it's here. What we would like to see is a protected computer system that would help to keep the palliative registry in the conditions so that any professional would see the code of a child and see everything in their dashboard. If something is being prescribed, we would be able to see the dynamics, etc. This would have made it so much easier. This would have made it so much nicer for any professional, no matter if it's in the doctor's office or not. That would take away a lot of the burden from the parents who lose all those documents very often. That's a simple, quick thing, but of course, these are expenses, and it's not that easy. The big thing that prevents us from development, it's happening globally, it's the certain discrepancy between the institutions. No unity. Of course, the funding happens when it comes to palliative care. It's always, let's say, the leftovers of the other funding. But that's what we're getting. In order to change this, we need to change the paradigm. For instance, obstetrics and gynecological services were earlier very much underfunded. Now it's getting better and better in a lot of countries. Now, I don't think that the society and the ministries believe that palliative care is a priority for adults and for children. I think it's still not seen as a natural part of the healthcare system. And if we are able to twist this, if we're able to shift this, it will give us more resources to organize the whole system in a more comprehensive manner. For this, I believe we need a very multidisciplinary association that would provide the politics that it's really a multidisciplinary work. It's impossible that it's only welfare or only medical services are engaged. We also need the Ministry of Education and to organize the collaboration with different countries so that this help would be like a standard, that it's normal. I don't think that it's perceived in the same fashion right now. The fourth question is how. Oh no, Julia, let's make a pause. The fourth question is coming. It's coming. We had certain hypotheses how PACE can help. We planned this strategic session after this webinar and after our school in Armenia. But based on what I've heard, there are definitely zones that we have not been thinking of, and I would add them to the fourth question. For now, let's focus on the questions 2 and 3. Yeah, The third, I would say, yes, the collaboration between the ministries and the society, so that it's not a promotion campaign, but that's a normal issue that is seen in a regular fashion. Now, if we speak to the ministry, we need to start off from the start.
So maybe Anna can start from Belarus. What develops quite easily, and where is the biggest problem? Please unmute yourself. Okay, got it. So, what I believe is easy to do is to standardize. Now we have everything. We have the registry, we have the system, we have the mobile team, we have the hospitals, the inpatient facilities, but we are still lacking standards, and we can do this easily. We love paperwork, right? And so our legislative work is going quite well. So to develop standards is a quite easy thing to do. Now let's talk about the challenges. What will be the most difficult thing to do? First, these standards should be working. They should be implemented. And this is about the communication as well as training. It's not only the training for doctors and nurses, but it's about raising awareness in the society. I guess that in our country, there is a challenge because we are all afraid of death. We don't even name it as death. Like when, for example, we ask, what happened to your father? The answer is, he's left this world, but it's not that he died. So we don't even use the word death. And we need to also overcome it. Actually, I was just rendering a psychological assistance to my colleague. Her mother died. Her mother was 101 years old, and it was a very difficult situation. So the societal change, the societal shift is needed, whether the society is ready for this or not. This is the most serious challenge for us, I guess. Okay, so I will just give some details on what was already mentioned regarding Belarus. I do agree about standards, but I think that what we can even do before the implementation of standards, we can also streamline our communication. So, for example, we can offer some consultancy in the field of social and psychological support. We can have these people who'd be of a great support for families, for parents. Actually, some consulting works very well for us. And the question of psychological support, I think that it's also quite an easy thing to do. We can even offer it as state services, paid by the government, right? Quite often, actually, our professionals in the state, in the public sector, they're lacking some communication. And here, we can also use the services of NGOs and their support. As to the most serious challenges, as we already discussed with my colleague Anna, now our parents don't have any choice. The babies, the children should be resuscitated and should be in the ICU for about 23, 24 weeks. It's a standard. Now parents can't choose. It's about intubation, it's about ventilation, etc. And even if there is a patient, a child with cancer, still this child should be supported. There is no choice of, for example, switching it off. Actually, 1 hour of a social worker costs $2. The question is, who will work for this money? $2 per 1 hour as a social worker. And this is the state or government funded framework for us. Okay, yes, Anna and Olga, thanks a lot of insights, because on the one hand, we should just be always beautiful, healthy, etc. But on the other hand, we have all of us, we have parents who get older, right? And who are about to leave this world and are about to die. And so what you mentioned about this fear of even naming death is very interesting. Now let's go from Belarus to Uzbekistan. Nodir and Rustam, maybe you can comment. So Nodir, what's developing quite easily for you and what is the biggest barrier? Hello, dear participants, dear colleagues. So what can we do easily? We've opened a hospice for 70 beds. So we opened actually it in 2 cities. And we also plan more beds in Tashkent and some others. So that's something that we are doing quite well. What we also did quite well and easily is the first pediatric hospice. So that's okay for us. But problems. The most challenging problem is the drugs and medicines. And so now we would like to get the long morphine forms and also we'd like to get some everything that is needed for this. What we are doing very badly, honestly, is the personnel management. We actually don't have personnel. Like we try to train some staff, right? Some professionals, but it's a real challenge. Yes, actually, we have a lot of professionals that are working in the field of palliative care, also in the field of oncology, and also a very serious challenge for us are the legal aspects, because we still need to improve our legal framework to make this all happening in a more streamlined way. But we are still like performing our first steps, right? Our pediatric hospices have been working only for like 1.5 years. We are a bit more experienced in adult pediatric uh, palliative care. And so we are still trying to work with universities to train more nurses, let alone doctors. Okay, Nadir, thank you very much. I wanted to ask you about the shortage of staff. What is the root cause of this? Because there were no opportunities to get trained, or because people don't want to work in the field of palliative care, even those who would like or who could do this? Okay, I got your question. So, first reason is because, well, actually, our palliative care in Uzbekistan has just turned 2 years, right? Before that, we just didn't have it. So we opened some centers, hospices, I mean, and it takes time. And the shortage of personnel. What do I mean exactly? Actually, we don't know whom to train and how to train, honestly. And this results in the second question, who will join this area? For example, we have a hospice and there are 50 beds, right? And the churn of medical personnel is quite intense there because some doctors or nurses can work there for like 2 months or 3 months and they want to leave because it's difficult, it's challenging. And those who stay in the hospices, we try to train those people to offer them some conferences and other training opportunities. Okay, thank you, Nadir. Rustam, would you like to add something about what's working well and what is quite challenging for you? Well, actually, I guess Rustam is more experienced in this. We already discussed these questions, and today we also listened to our colleagues. And actually, I realized that it's still like a long way to go for us to reach the level of palliative care development that is already present in other countries. Okay, so I would also like to add that, well, you know, we've been doing this for 2 years and we've already done a lot, but still, we can do a lot of many more things. So first challenge is the personnel shortage. So we don't need to reinvent the wheel, right, and the bicycle. There are some standards. And there are some countries, actually in the post-Soviet area, our legislative frameworks are quite similar, and we can take cue from our neighboring countries, right? Sometimes, actually, what's funny is that when I read our laws, I see some misspellings and mistakes, like because they say it's the Russian legislation, so they just forgot to change when they copied it. That's my main idea. So indeed, when it comes to death, it was a tabooed topic for us, but we're really trying now to raise awareness, because we would now like not only to make the population but also the stakeholders to understand how to live with this and how to work with this. The second question, whom can we train? Well, we need to train psychologists who speak our local language, and also we need to train doctors. This is the most serious challenge for us. And when it comes to the legislation, well, actually, I guess that we will get the new law on palliative care in 2 or 3 months. And so we've been progressing here quite well, and I hope that, it'll be going quite fast. But the personnel shortage is indeed a challenge for us. So that's the general overview. Thank you. Thank you, Rustam. And now let's go to Kazakhstan. Yulia and Nurila, who'd like to speak first? Well, as to the zones of improvement, areas of improvement, we've just opened the Pediatric Palliative Care Department in Astana, and this is the Center of Palliative Care that is developing quite well now. This is the place where today we offer good support, good care, and also we have the good understanding of the concept of palliative care. But this center also needs some finance support. So, as my colleague already said today, we are still developing the pediatric palliative care standard at the legislative level, and it's a huge challenge because unless we get the standard, we won't have anything to proceed from. And the second question, just our colleagues already mentioned the shortage of professionals. We don't have such a position as palliative care doctor, and that results in the absence of training programs that would allow us to launch full-fledged palliative care. And also we lack some infrastructure that would help us to perform all our functions well. Unfortunately, this is not present today yet, but these questions are easier to resolve, I guess. And also we have NGOs who actually support us a lot immensely when it comes to the development of palliative care in our country. And actually, thanks to NGOs, we do have those development areas in the field of palliative care. And as to the most serious challenges, the second part of the question, well, actually, we can do everything if we have enough willingness and finances and resources. Here, I agree with my colleagues from Belarus and Uzbekistan. It's about the recognition of death. Like, we can't really change these attitudes very fast. So there is underestimation of palliative care, and we need to shift this mindset, this behavior. And this is something that is quite difficult to do. And the knowledge about palliative care is not still that widespread. So this is something that we would really like to improve and develop. Thank you, Yulia. Nurila, maybe you could add something. Yes, right. So what Yulia has already mentioned, I agree with this. We need to distribute the experience of our 3 leading cities that already got palliative care centers. We need to communicate to the public authorities that we need to have separate palliative care centers, not only palliative care beds in some general hospitals, but we need to have separate centers for this. And we also need to understand what does a palliative care doctor look like? Who is this specialist? And today we are already introducing some training programs at our university. Those are the programs in the palliative care, not only pediatric one, but the general one. So actually now most of our pediatric palliative care patients, they are our out of patient facilities patients. And so our doctors also need to understand what categories of patients they will face in their professional duties. Those are two main zones and areas of our growth, and I do hope that we'll be able to organize it properly. Thank you. Okay, thank you. And now I'd like to give the floor to our colleagues from Georgia. Irakli, Nino, who'd like to answer? Irakli, please unmute yourself. Can you hear me now?
Yes. Okay, well, I will start with the areas that we have a certain growth, although I want to mention here that I don't think there are any areas that are particularly in a rapid growth in Georgia in palliative care, but the area that we notice the most growth, I would say, is home care services. And also with the palliative care departments at the hospices that are being developed. But all these areas, I say, face the very similar difficulty zones, and they're also, of course, addressed with the policy. We do have a developed policy, but again, it looks much better on the paper that is in the practicality. Of course, these home care services, they have a very, very low paid job, paid wages. The platform that you have to register isn't all the way developed yet. So there is still a lot of work to be done in that sense. That's why I want to say that I cannot call that we have a rapid growth, but definitely in the area most notable will be home care service. As far as the difficulties, I would list the major difficulty we're facing is workforce development, even though there are there are trainings that are available for people, for example, who want to register at the as a part of the home care service. But our staff also participated because it became mandatory. And honestly, just a 62-hour training, which allows you then to be a part of a home care service. And I disagree that it's a holistic training. I think it needs to be given a little bit more detailed, a little bit more practical training to have a more holistic approach to the home care service and to have a better trained staff, especially given the reality, which I mentioned earlier, that a lot of specialized staff is leaving the country. Pain management approach needs to be radically overhauled in the country on the policy level. And another area that needs to be developed is definitely we're having difficulties in developing today is servicing children in regions. And it's also connected to mostly with the financial resources and how the hospitals in regions are fitted with equipment and also the workforce that they have available to them. In general, I would also mention here the general awareness raising of the public, because also in this public, I also mean those people who are working on the policies. Of course, there are a lot of specialists from the palliative care, but oftentimes you are defeated by the administrators and lawyers who are sitting on the other side of the table while working on the policies. So this is what I mean by awareness, both in general public and by in the awareness also needs to be stressed towards the cultural and social attitudes. Other colleagues, mentioned how people look at the death, how people look at the hospice in general and palliative care. So it's definitely, in our case, is closely related to cultural and social attitudes.
Иракли, спасибо большое. Нино, хотите ли добавить что-то?
Thank you very much. Nino, would you like to add something?
Видимо, нет.
I think so, then, I believe. Okay. Dear colleagues, thank you very much. That's been very helpful. This remark that what is matching and what is different. Julia, the floor is yours. Maybe some of the questions or some of these areas, maybe you have some answers or some best practices that we can relate to. What have you noticed of those growth areas and the challenges and the obstacles?
Okay, thank you very much. So it's great to hear that in, I think, all of the countries you were able to identify some low-hanging fruit, some things that you can move forward on, which is great. But there were some, I think, challenges that were key across all of the countries. So if we start perhaps a bit with that last one, it's around society's understanding of not just of palliative care for children, probably, and for adults, but also some of the cultural and social and societal attitudes around death and dying, around not talking about it. And yet we know that the one thing we all can be certain of is that at some stage each one of us will die. And yet within society, we don't want to talk about that. So there have been examples in different parts of the world of campaigns to try and address that. For example, in Malaysia, they were talking about the elephant in the room, and within the big shopping center, they had lots of models of elephants, and they were talking to people who were doing their shopping about palliative care, about death and dying. In the UK, they did a study recently which looked at how do we talk about children's palliative care? How do we talk within society to try and change attitudes? The three things that they came up with was that we need to show how children's palliative care is at its best, so have stories about the difference palliative care makes, show how children get to be children, and think about the quality of relationships that are enhanced, but above all, talking about children's palliative care, about life. People see palliative care being about death and dying rather than about living. So trying to refocus how we talk about death and dying and children's palliative care. Those are just a couple of examples, and there are other examples around the world of ways that people have tried to change society's viewpoints and to work with society's understanding. And that includes getting the press on board, working with the media, etc. So that was one area, I think, the public and society. Another area was political will. And that is always a challenge, and that takes a lot of time and advocacy. And I know many of you have been sort of advocating at the political level for many years. I remember one time I was in a taxi with some colleagues, and one of them had a phone call from one of the ministers saying that their mother needed palliative care. And although it wasn't children's palliative care, the fact that that minister had rang because they'd recognized the need for palliative care, and we knew that if we got it right for that minister, then there would be a voice there at the government level. We've done in many countries work with governments, with MPs. The challenge, of course, is that they change. Governments change, and how do we make sure that there is continual advocacy and continually working with the government to get political will, to get understanding, to get a national strategy in place, and that then will lead to funding. So those two areas that are kind of big areas that take time, but there are examples from different countries of how that has been achieved. The other two things just to say here were continuing around education, making sure, I think one of the challenges was about human personnel, but also about not reinventing the wheel. We've done some work looking at over 120 training programs on pediatric palliative care around the world, identifying the core components of those programs. So let's not reinvent the wheel, let's share, let's learn from each other in terms of education, both at the specialist level, but also at the more generalist level. And then, of course, funding, financial resources, and within that, I think several countries said that the wages for people working in pediatric palliative care are low. There isn't necessarily any career structure, any recognition, and so trying to look at that. And then I think the final one several people mentioned was around access to medicines. That's just a few of the points, but there is, I think, the important comment about not reinventing the wheel is key. Now, I know we cannot take something that works in one country and put it into another, but we can learn the lessons. We can take some key points. We can adapt existing standards. We don't have to start from scratch all the time, as long as we make sure that they are appropriate for our country, for our cultural and societal attitudes and issues. That is so important. Thank you.
Джулия, спасибо большое. И продолжая...
Oh, yes, Julia, thank you very much. To build up on that, I'd like to bring to the question number 4 that we have identified for today. How can the international community help solve the important issues or the barriers that you have identified? Here, you can suggest specific questions, some specific proposals, or some wild ideas, wild fantasies. Sometimes we don't even understand how an international community can be of help. It can be something beyond very evident. This can be the question of experience exchange, or this can be best practice sharing. This can be really anything. I welcome you to join us for this conversation in different level of detail. So maybe you can fantasize of having a group of lawyers who could work together onto what are the best practices globally that can be attributed to our legal system. This is just my fantasy, my assumption. Some of the ideas may be fun, some of them might be ridiculous, but that's okay. Please welcome them. And you can also share some very practical things. Let's begin. Let's begin with, once again, shuffle everyone, the order of communication, so that everybody can find themselves in different locations. Let's begin with Kazakhstan. Yulia, Nurila, maybe you can share your comments. I know you are doing a lot of international activities already, but from what could support children palliative care, pediatric palliative care, what of the value or the needs you see when it comes to the interaction with professional international community? Nurila, would you start? Yes, dear colleagues. Thank you so very much to the organizers and Anastasia and Irina for this fantastic forum. I hear a lot of experience, at least my colleagues, I hear that. I think the international community, I think what we should do is criteria for the transition into palliative care. For example, now we take this international classification of diseases. Sometimes we're using very physical status. This becomes a huge cohort to choose between the options for the doctors who are inpatient, for the hospitals, polyclinics, for the home care professionals. Well, First, we take this international classification of diseases, and then we take the local standard. Perhaps if there are some clear criteria, this can be very helpful to see, because the work that we are doing, I think why I'm referring to the Association of Palliative Care for the Child of Kazakhstan, it's a huge work. They're working through the governmental bodies. They write letters, they help. And in this regard, how do we select? Do we choose the physical status or some other status? Nosology, pretty much every nosology. You can take it pretty much anyone to palliative. Are we taking stages of diseases? What are we talking here? Thank you, Nurila. Yulia, what do you think? I think we should not reinvent the wheel. Everything is there already. I think the good thing could be, the good background could be a good research for our lobbying, for our advocacy services, to reach the ears of the ministries, to reach the understanding of the government, maybe the appreciation and the evaluation of the global experience. When we bring in the professionals from abroad, so that they could help us with the research. I know it's been done many times in different countries, but if this is done with Kazakhstan numbers, with the Kazakhstan realities, for the parliament, for the ministry, that would be more weighted, more strong as an argument. Thank you, Yulia. Whom did you yield the floor to? I'm sorry. Irakli, maybe the floor was yours.
Да, вам. Только звук.
No sound. We have a sound issue here.
Okay, what about now? Can you? Great. Well, I mean, I think we all agree that there is vast amount of resources available out there. I mean, I think I've mentioned at one of our earlier meetings with PACE, and obviously there wasn't this group of people there. But I think the really great help is from the international organizations will be somehow developing a very comprehensive database of available resources specifically for palliative care. And in this, what I mean is maybe a section where there will be a database of financial resources, like through different grants, like who are those organizations that specialize in helping out the palliative care houses. Also resources in terms of, it could be specialized used furniture that some houses are donating, and if it will be available somewhere in a centralized place so we could all access, and also the resources knowledge-wise, because I know that all these centers are having and developing like we have very small amount, but we are increasing gradually on like small, we call them cards, like educational cards for parents, for caregivers that are written on a very basic and understandable language. So if there are other hospices and experts around here who, for example, PACE, you guys joined us somehow together through your platform, we can translate them, we can share them. Also, maybe there is a volunteering resource out there also available. So I really think that, I mean, there are tons of international organizations, starting from World Health Organization, ICPCN, PACE, I mean, all of them, Open Society Foundations, who give out all these resources. But honestly, like, I found it really hard, somehow mobilizing and searching all these available resources. So I think bringing them somehow together could be a really, really huge help from the side of international organizations and community.
Спасибо большое, Иракли. Давайте
Thank you so much, Irakli. Let's move on to Belarus, maybe. Anna, Olga. I'm sure you have it all, but there are certain things that you can be helpful with. Oh, just the sound is off again. That was a good start, I'm sure, but we didn't hear it. Not yet. Okay. I'm sorry. My mouse is running around everywhere. Just ran away. I'm sorry. What we need is, first, I would agree with my colleagues, with many of the colleagues who have spoken. Everything that was said, I would support. But what Belarus would need, as I mentioned, Yulia was mentioned, palliative care is not about death, it's about life. Julia was mentioning that. But for me, palliative is always a balance. This is how I was taught. This is always the balance between life and death. And this balance should be kept. What I personally see is that the balance is broken. Now it feels like, oh no, there is no death. We are living till the end. No problems of diseases. We're going to reanimate for 24 weeks. Or the child with osteosarcoma, we're going to reanimate this child as well, because we have this criteria, this KPI as death rate and survivability. But what I think we need is, to me, palliative care and intensive care unit. I think we need clear recommendations. Whom we are not taken to intensive care units, whom we are not ready to reanimate. Second is, who is our patient? I don't fully understand. Now anyone can be a palliative care. Take me to palliative care now, because I'm also old enough, you know. Who is this patient? I think we need a research and the documentation that this is a palliative patient. I think we've done the inclusion in such a way that we don't really see the boundary between where we see palliative care and a non-palliative care. And the last thing is my favorite topic. I come from oncology. To me, it's very important. It's oncology. We lost it in our country. Again, I'm studying here with you. We cure till the end. If Belarus doesn't care, we go to Russia, we take chemotherapy, we have targeted chemistry. And where is palliative? A child is in the first group. How can we help? Psychologically, okay, let's learn about that. How do we speak to a child who is in the first group, but there is target chemistry? Are we speaking about child's life or death, or about elderly years, or what are we talking here? I think we need to learn. We need to learn here. Olga will share her opinion. Olga will speak about preterm birth, etc. But I think it's the question of intensive care units, reanimation. We need to learn to communicate. And I would say we need, as doctors, I respect doctors, but the doctors should have algorithms. They need to understand how they speak here, how they speak there. They usually ask for algorithms at my courses. 14 consultations a day. I think everybody needs an algorithm, at least a preliminary one. That's what we should work on, I think. Thank you, Anna.
России существует в виде телефонного звонка, и кем вам приходится, гражданка Иванова? И ты сразу понял.
Да.
Ольга, есть?
Well, I think, Olga, would you like to please add more on here? Yes, I would try to focus not only on preterm children, but I'll speak broader. In Belarus, we have the NGOs that we would be very grateful to any non-commercial organizations, NGOs, who face palliative care. This may be informational support, brochures, leaflets, financial grant-based support, educational support. This is what Anna talked about. We do miss the standards, that's true. But on our side, I see us as a public organization. We are part of the European Association of Preterm Child Support. This is the standard that is spread to 90 countries. Unfortunately, they're not integrated in the state level, but we understand what we are based on. These are general norms, then we say this is how it should be. So far, it's not the case. A mom should be with a child, yes, but how can we ensure that? There's another moment that is connected to It is connected to a certain integration of successful international, non-commercial, and state service of palliative care as well. I think with research, maybe with some data, where does this partnership between private hospices and public state service, how do we find this synergy? How can we integrate that? How do we transfer this information to state services? Because de facto, there are certain standards that WHO supports. Yes, the country has to comply with these standards, at least in some questions. Somehow there are not enough of practices, research-based, clinical proven practices that we can deliver to state sector.
Thank you, Olga. Colleagues from Uzbekistan. Rustam is still here. That's very nice. So maybe you could comment. So first, thanks a lot for this roundtable discussion. I do hope that our cooperation will be a long one, and also we see a lot of useful experience from our colleagues. For us, it's very valuable because I guess we are the youngest ones in this respect. Maybe Tajikistan will also join this movement later because we are also helping them to promote it. So what can the international community and the organization, the foundation, do to help? Well, first, training. Maybe you have some standards. Maybe we can translate it ourselves. That will be of help for us. We also have a 4-year plan, and we got the financing for the development of palliative care. And so we got the finances to develop the training, etc. But now we also need to understand where we can send our professionals to get trained. It's important both at the legislative level as well as at the level of our mindset, right? I don't really like this word mindset, but it's very important in palliative care and in hospices. And so the rest is that our government and our people have started to listen to us, to what we are saying about palliative care. And I think if we manage to prove that palliative care actually can save a lot of resources as compared to some other types of medicine, this will be quite beneficial. And I hope that we will be able to achieve our goals. But the training for us now is the key. Well, and we continue to contact people, and I do hope that also we'll get the minutes from today's panel discussion. It'll be very useful. Thank you very much for this opportunity, and thank you for the discussion today. Thank you, Rustam. Nadir, maybe you can add something. Right, what can I add? Well, we have both problems with adult hospices and pediatric hospices. Now we've allocated 10 beds to become the pediatric palliative care ones. We started to work with foundations actually now, and I do agree with what was said about the challenges in Armenia and in Kazakhstan. Obviously, we still have to grow a lot to reach the level of Belarus, and I'm sure it's going to be a bumpy road and ride for us, but still I do hope that in 20 years we'll be able to catch up with Belarus level. And so as to the finance, well, palliative care requires some financial support. And what the government gives to us now, it's enough and sufficient to maintain the current palliative care level, but not to develop it. And so we need to search for some alternative sources of financing. And for the past 1.5 years, we see that our people started to pay more attention to palliative care. Because the first time they heard or saw something about hospice, they were just surprised and shocked, basically. And also, it's connected to their religion. But slowly but steadily, or as we say, with the speed of a reactive snail, we are moving forward. So slowly but steadily. Thanks a lot. So I see that everybody have switched on their cameras. So could you please raise hands those who also attract some commercial companies to support some palliative projects. Okay, Latvia, Belarus, Armenia, Georgia. Great, thanks a lot. Because Nodir said that the finance is enough to maintain palliative care, but not to develop it. But I know that some countries also have an experience of cooperation with businesses. And we also wanted to discuss this topic about fundraising. What are the options there? So now I'd like to give the floor to our colleagues from Armenia. Anush, Narine, what help do you think you can get from the international community to continue developing palliative care in Armenia? Well, first, I think that we need to still have some course for pediatric palliative care, because we have a license and it says that a professional who should and can work in pediatric palliative care should have an at least a 2-week training course. And we need actually some courses for this. And one more thing, it's about the registry. We would like to develop this registry, and after we develop it, we'll understand how many children we have, how many other patients we have, what they need, whether the nutritional support is needed, whether some other kinds of support are needed, such as with opioids, etc. And that's how it will be more transparent how much money we will need for all of this. Because now the finance that is provided by the government for the hospitals it's not enough for everything that we want to do. Actually, it's not enough at all. Thank you, Anush, and maybe Narine can also comment. Maybe Narine, I'm afraid, has some problems. Well, now we'd like to give the floor to our colleagues from Latvia. So you have very good connections with the international community, and you've been doing palliative care for quite a while, but still maybe there are some other areas to improve. Right, I would actually like to mention 3 main blocks. The first one is information and information exchange. This actually helped and has been helping all the countries, including those that are represented today. This is also about best practice sharing and exchange. And this is particularly important in relation to innovations. I suppose that, as Julia mentioned, well, there are 120 training programs, and I guess that there are also some standards that serve as a foundation for all of this. But I think that each and every country needs to prove that they need palliative care, pediatric one, and why. And I think that indeed we need to show that it's useful. How can we do this? For example, we can run a small joint research project, and this will serve as a foundation to show that, for example, we did this research and we proved this and that, and then we can also use this experience in multiple countries, because it's good to unite efforts to do some projects and research. That's how I see it. Those could be different research projects, because each and every country needs to have the tools and resources why palliative and especially pediatric palliative care is needed. Next idea. Well, I guess we'll also have some conferences together, and it's very important to invite representatives from ICPC and from the WHO and from other organizations, because all the decision makers and civil servants need to listen about this with their own ears. And what's important for me personally is we can organize some event. This could be a round table or some short round table of training about advocacy and lobbying of these questions, because every country needs it, regardless of the level of palliative care development. Thank you. Right, thank you. I do agree with my colleague. So on top of innovations, it would be interesting and useful to pay attention to the criteria of performance in palliative care, as well as the quality assurance in palliative care, because, well, actually, I know that in the US this work is now being done, and that's how we can prove that palliative care is efficient. It's difficult to work only with hours, for example, of visits, etc. We need to use some framework that is recognized around the world. And also on top of the innovations, we also need to have some center which will help us to include our children in different researches, because the common problem of a lot of studies and researchers is that there's a shortage of patients, right? But this is a real window to new knowledge. And also it's very important to prove to the families, children, and their parents that they are part of the international community in this respect, and they can also contribute with their studies and with their participation. And also we can organize some multidisciplinary meetings in events in any format, both offline and online, because the question of the pediatric palliative care needs to be discussed. Also, we need to discuss the death. We need to communicate that death is a normal element of life. We should explain that it's also a norm. We are born and we die, and we should raise awareness about this, and this could be a joint project. For example, now we can see how this work is done in different countries. It's very nice that there is a lot of enthusiasm about this. We want to develop it in any country around the world. Thank you. Yulia, thanks a lot. As to the interdisciplinary meetings that you mentioned, we also stand ready to be of help here. And of course, we'll need your feedback, and also you should explain what colleagues you would be interested in inviting, because we do have a community already, but we also have some disciplines that we are still lacking, to which we don't have access yet. Right, thanks a lot. It's also very nice for us to learn about Armenia. We'll also come to the summer school. We do have summer schools in Latvia, but now we are going to Armenia, and it's very nice to learn about the experience from other country. Right, I think this could be a very good start. Now I see there's an exchange of contacts in our chat, and you can also just contact each other directly and ask about some internships and some joint projects. Okay, let's sum up. And now I'd like to give the floor to Julia Downing. So, Julia, of course, you have a very extensive experience in international cooperation in palliative care. Maybe there are already some opportunities and practices that we need to be aware of, or maybe you can share some experience how to build the most efficient cooperation. The floor is yours, Julia.
Thank you very much. And this is always a challenge for all of us, as to how best we can learn from each other and cooperate with each other, not reinvent the wheel. So, for example, one of the things that's come up quite a bit is the issue around research. I think that in our last colleagues were talking about the importance of being able to demonstrate the impact of our services. And there is the development of a children's palliative outcome scale, which is being developed in different parts of the world. And that would be an area that it would be good to try and link in with, to try and adapt and develop an outcome scale for children's palliative care that works within the region, in the appropriate languages of the region. So that's an area that we could continue to link in on. Another area of research, I think it was Anda who was saying the importance of actually understanding the need for paediatric palliative care, and then how we could perhaps do something together on that. And that's something that we've been doing in several countries, doing needs assessment, and then out of that getting commitments and recommendations from the government, and then developing services out of that. So, you know, we've got protocols and things that can be used and adapted to do that. And, you know, estimating the number of children needing palliative care in each country. Again, we've been working with the Lancet Commission with a range of people trying to estimate the need for paediatric palliative care globally, and then in different countries. So we're just about to hopefully get that published, and once that's published, then we can happily work with all of you on that. I think somebody was asking about the kind of essential, what is essential really in a paediatric palliative care program and the costings for that. And again, there's some work being done currently through the University of Edinburgh, the IHPC and ICPCN are involved in that to develop the essential package for children's palliative care and an advanced package, and then look at the costings for that as well. So that there is work going on that it would be great to link in with all of you and to develop as appropriate. Education, yeah, there's a wide range of education programs. Resources is a key issue, and I think that came up from Georgia, from our first one of our first presenters together, and we are looking at that at ICPCN. How can we have a central hub that really is a central hub that brings together resources and resources in different languages? So that is something that is ongoing. But I think it's really good having forums such as this where we can share and learn from each other, and see how the regional and the international community can work together to support paediatric palliative care development, sharing experiences around advocacy. I think that might have been Anda again saying, you know, having some training on how do we advocate for children's palliative care. These are things that we should be able to link in with PACE, but link in with all of you as ICPCN. So I think it's an ongoing discussion, how we learn from each other, how we collaborate and share.
Julia, спасибо большое. Я надеюсь, вам тоже было интересно и полезно.
Julia, thank you very much. I do hope that it was also valuable and interesting for you to see the challenges and the movements that are happening in the countries that are presented today in Eastern Europe, in Central Asia, in the Caucasus countries. I'm sure that you are quite well aware of a lot of things, but I hope that you also learned something new today.
Yeah,
colleagues,
definitely.
thanks a lot for our roundtable. Right, so thanks a lot for being with us. We had a whole set of webinars on palliative care in different countries. And so if you or your colleagues are interested in information about some particular country and you didn't participate in our webinars, we have recordings, we have minutes, notes. So we had 5 webinars that described the different countries. And please get back to this if it's needed. We'd be very happy if you will also share all the materials that you get from us with your colleagues, those who share the same palliative care values, because it will also be very important for us to get feedback, how we can be of help even more. Please contact us in our chat, in our group chat, in personal messages. For us, it's important to proceed not based on our personal feelings, but indeed proceed from what is needed in different countries to continue developing palliative care. Thanks a lot. That was very valuable for us, and we'll keep in touch. And so we'd also like to thank our interpreters, Christina and Anna. Well, it's a simultaneous interpretation, and our interpreters also try to learn a lot about palliative care in the based countries. So actually, if you need interpreters in the field of palliative care that work with Russian and English, please contact us so we can recommend our interpreters. Thanks a lot. Have a good week. We started it from this international cooperation and discussion and some positive developments and news. Thanks a lot. Keep in touch.